Thank you, Mr. Chairman, and thank you both. I read your statements. I wasn't able to be here, but I have a question for each of you, and I know I have 5 minutes, so we can base it accordingly. Both of you discussed the fact that we lack primary care coordination of and incentives for primary and preventive care. Mr. Elmendorf, you mentioned in your testimony that the potential effects of initiatives where we might invest more now, which preventive care is all about, and not realize the savings until later. This would be certainly true in efforts to offer preventive care services, but right now the CBO doesn't even allow us to account for savings. And as I've often said about a field that I care a great deal about, which is preventive health care as a public health nurse, there's no special interest group pushing for preventive health care. And so my question is, how do we integrate into our proposals a way to realize that the savings later are what we're investing now for? And if you could give me your response to that. I have a different question for you, Mr. Heckbeth.
So, Congresswoman, CBO does not just as a blanket matter ignore the health effects of changes in policy. The tobacco example was raised earlier as a case where we very specifically look at the effects of higher tobacco taxes or tougher tobacco regulation and try to trace that through to the effects on spending, for example, in Medicaid, the number of premature infants that are born and the costs of that. We are very actively looking for evidence to help us trace through the effects of changes in policies on health and then on federal and on private health spending later. So in no sense are we putting those issues to the side. We are focused on them. The problems that I mentioned are lack of evidence in many cases,
right,
or very long-run effects in many cases, and it's just more difficult to trace things out over several decades.
When you talk about tobacco smoking, it's a specific act, and when you talk about prematurity, there's a specific entity surrounding. I guess what I'm talking about in the area of prevention, some harder measures that are maybe more pervasive. Comprehensive health education for kids in a school curriculum, some subject dear to my heart. Most school curricula have no place for it today, and if we were to target things like that, maybe not that specifically, where it's general education but targeted toward preventive health care, are you looking to us or to some some study group to measure the impact of the input and then some kind of impact and outcome?
Yes, so we look to outside researchers to guide us in the choices that we make in our estimating process. So on the tobacco front, there's been a wide range of research about the effects of tobacco.
How about obesity and diet and exercise?
And I think that as well. I think on obesity, there are several steps of the prevention that have to work. So I think there is a good deal of evidence about the effects of obesity on health problems, less on how particular public policy changes will
So that's what we need to work on.
And that's when we look for.
And I hope there are some outside researchers listening who will help us take the ball. I want to turn to another topic, but that's one that certainly needs to be explored further, and I appreciate what you just said. Mr. Hackbarth, in your testimony, you alluded to the declining number of medical students pursuing a career in primary care. This has been well demonstrated. Could you please expand on how you drew the correlation between Medicare reimbursement structure and this decline? And if I could just roll all my questions together, you'll understand. Could you offer some suggestions on how we would need to restructure a payment system to incentivize primary care, and how this would then spill over to private payers? That's not too much for one.
So in the first question, the relationship between payment levels and the decline in interest in primary care, I'm not going to be able to point to particular studies off the top of my head, but we could...
Maybe you could get back to us if you know of some.
But certainly in talking to people involved in medical education, including some of our commissioners and other people that I work with in other walks, what I hear from them over and over again is that medical students, considering their career options, often point to a couple things about primary care that make it unattractive. One is the income level relative to other specialties. Second is the demands, the lifestyle demands that they experience in primary care, as opposed to some of the other specialties.
Could I interrupt by just asking, do you think the cost of medical school has anything to do with that?
It
I'm
could.
seeing a lot of people nod behind
Yeah,
you.
it certainly could. Obviously, if you're making a salary or an income that's 2 or 3 times larger, you can pay off those medical school loans
Exactly.
a lot faster. And so the cost of medical education is not equal for all specialties, but it tends to be a real problem for people considering primary care. As far as what to change, we've made 3 types of recommendations. One, you're familiar with the process of establishing the fee levels, the relative value scale, and we've identified what we think are some problems with how that process works. In particular, we think the process focuses more on things that are undervalued and increasing values than things that are overvalued that need to be reduced. The net effect of that bias that we've seen in the system is to hurt primary care
Exactly.
fees. And some steps are being taken to reform that process that we're cautiously optimistic about. The second thing that we've recommended is what we refer to as a primary care modifier. It's basically a bonus for physicians and other clinicians who, through their practice, demonstrate that they're committed to primary care. So it would be a modifier. You would get your fee plus an increase of 5 or 10% if you are designated as a primary care clinician. The third thing that we've recommended is a large-scale pilot of the medical home idea, a key element of which is to say for primary care, because of the unique nature of the specialty, we ought to pay not just fee for service, but on top of that pay a lump sum per patient to cover activities that are not included in the Medicare fee schedule, various counseling activities, following up on specialty referrals and the like, plus give primary care practices money to build some infrastructure, including hiring staff that would allow them to more effectively coordinate care, especially for complex patients.
Is that proposal? I'm so sorry. Oh, I know. I'd like to follow up on that topic
Be
with
happy
you,
to
too.
talk more about it.
Thank you.